Hello, and welcome to Digest This, where we discuss clinical topic in gastroenterology. My name is Francesca Moroni. I'm one of the gastroenterology consultants in the north of Scotland. Today we are discussing Hepatitis E virus, and I am delighted to introduce to you Dr M Donnelly, a consultant transplant hepatologist and gastroenterologist at the Freeman Hospital in Newcastle. Welcome, Mari.
Thank you for having me today.
Well, when we think about hepatitis E and remind ourselves at the time of medical school, we always think about developing world type of virus. And then we start practice medicine and we completely forget about it. But things have changed. And why we should be aware of hepatitis E as a cause of acute liver injury in our cohort of patients?
So I think you're right, Fran, and our understanding of hepatitis E has really changed significantly over the past decade or so. So you're right, and when we were at medical school, we all remember being taught about what we now know to be genotype 1 and genotype 2 hepatitis E as obligate human pathogens which caused large waterborne outbreaks, predominantly in developing or resource-poor countries. I guess we now know that there are 8 genotypes of hepatitis E. And really in 2008, our interest and knowledge of hepatitis E peaked again when a group from France described chronic infection with hepatitis E, and this was genotype 3 hepatitis E, which could subsequently progress to cirrhosis in patients who were immunocompromised, and in particular the solid organ transplant population. So as I say, we now know that there are 8 genotypes of hepatitis E, and I might just quickly talk you through each of those. So genotype 1 and 2 hepatitis E, as we've talked about, are predominantly infections in the developing world, which are obligate human pathogens and cause large waterborne outbreaks in addition to sporadic infections. Genotype 1 and 2 tend to affect young patient populations, and in large outbreaks there's a mortality rate of around 0.2% to 4%. But again, we'll all remember from medical school that these infections are associated with a high mortality in pregnant patients. There's also a high mortality in cirrhotic patients who develop genotype 1 and 2 infection, and the Indian groups have described up to 70% mortality in genotype 1 and 2 infection on the top of patients with cirrhosis. So as I say, in 2008, the European population became aware of genotype 3 and 4 hepatitis E infection, and this is a largely zoonotic infection, so passed to humans from animals, and the pig is the primary vector. And I think we're all now aware that undercooked or raw pork is a significant risk to humans for HEV infection. Many infections with genotype 3 or 4 are acute and self-limiting, but as I say, we are now aware that these can progress to chronic infections, particularly in patients who are immunocompromised. Genotypes 5 and 6 predominantly affect wild boars. Genotype 7 and 8, in fact, have been recorded in camel populations, and there is a case of a liver transplant recipient in the Middle East who contracted genotype 7 hepatitis E infection from drinking camel milk.
So it seems that hepatitis E is not simply a self-limiting hepatitis like any other orophycal transmitted hepatitis. Did you have any comments on that?
I think that's right. So, hepatitis E really is a virus with 2 faces. So it behaves differently according to the geography and the genotype of the virus. So as I say, genotype 1 and 2 commonly is acute and self-limited unless the patient is pregnant and in their 3rd trimester or has underlying chronic liver disease. But the vast majority of people with genotype 1 and 2 acute infection will clear the virus spontaneously. Genotype 3 and 4, as we've talked about, are more common in the European populations. And again, the vast majority of patients will clear genotype 3 and 4 infection spontaneously if they are immunocompetent. Patients who are immunocompromised, so for example, solid organ transplant recipients on immunosuppressant medication, patients with HIV, patients with hematological malignancy are at risk of chronic infection, and we know that patients, for example, who are immunosuppressed in the transplant setting, around 60 to 70% of those will go on to develop chronic infection.
Could we acquire hepatitis E from transplanted tissues or organs?
So because hepatitis E is very common in Europe and is most commonly asymptomatic, hepatitis E infection has found its way into the blood supply. The first recorded case, I think, of hepatitis E being transmitted via blood products in the UK was in 2006. There has been a more recent study in England looking at the donation of blood products infected with the hepatitis E virus, and up to 42% of patients who were given blood products from donors who were viremic at the time of donation developed infection, and 10 of those patients went on to develop chronic infection. So bearing in mind that the risk of transmission via blood products, a number of European countries have gone on to look at seroprevalence in their blood donor populations. And by seroprevalence, we really mean the prevalence of IgG antibodies against the hepatitis E virus. In Scotland, we have recently assessed our epidemiology of hepatitis E virus by looking at the prevalence of IgG antibodies in the blood donor population. So across Scotland, the seroprevalence is 6%, but there is a geographical variation. So for example, the seroprevalence is much higher in Edinburgh than it is in Aberdeen. And this is in contrast, for example, to the population of pig farms. So it's in contrast to what you might think the seroprevalence might be.
I suppose this comes at a comment that years ago came out as hepatitis E being the Brexit virus, rather our pig may not be infected by it. It's really important that we don't miss the diagnosis from what you're saying in our patients with cirrhosis, or above all our transplant patients of hepatitis E. So how do we ensure we picked up these conditions?
So I think that's a really important question, and the diagnosis is predominantly made by testing blood or stool. So in the immunocompetent patient, antibody testing is sufficient and IgM testing can be performed. If the IgM is positive, that is suggestive of an acute infection, but it is good practice to confirm that either with RNA testing or monitoring for rising IgG titers. However, in immunocompromised patients, so for example, transplant recipients who are taking immunosuppression, there's altered IgM antibody kinetics, there's a delayed immune response in these patients, and therefore there is a very high false negative rate of antibody testing. So in these patients, you really need to rely on hepatitis E RNA testing by PCR, and that can be performed both in blood but also in stool. And it's important that if your lab offers stool testing for hepatitis E RNA that you use that service. So there's good evidence now that there can be prolonged viral shedding in stool after the virus has been cleared from plasma. And if the hepatitis E RNA is still positive in stool at the end of treatment, which I'm sure we'll come on to talk about, that is a predictor of relapse.
Well, it's interesting you mentioned about treatment, because I was going to ask you, should we treat hepatitis E? Can we do that? And if so, who should we treat?
So there are treatments out there, and I think whether you choose to treat a patient depends on whether the infection is acute or chronic, and whether a patient is immunocompetent or immunocompromised. And I guess we haven't actually defined chronic hepatitis E yet, and I'll maybe come on to do that. So if the patient has acute infection and they are immunocompetent, the vast majority of patients will clear the virus spontaneously. There are some indications for treatment, and we're talking about using ribavirin in this setting for patients with acute infection. So for example, those with a severe acute liver injury, those with acute liver failure, or those who have extrahepatic manifestations of hepatitis C, for example, Guillain-Barré syndrome. These patients may benefit from treatment with ribavirin. In patients who have chronic infection, and by that we mean positive HEV RNA in plasma or stool for 3 months, the first therapeutic option is, if they are immunosuppressed, to consider reducing their immunosuppression. So we know that if you reduce patients' immunosuppression by around 30% of their total dose, 30% of patients will clear infection simply by reducing the immunosuppression. And that effect is predominantly seen by reducing tacrolimus dosages in patients with or who have undergone solid organ transplantation, as these are medications that target T-cell responses. For those patients who don't respond to a reduction in immunosuppression, then ribavirin is the best described treatment. And ribavirin has been used in this setting since around 2011. The evidence predominantly comes from case series and case studies rather than randomised control trials. And the case series all use a number of different dosages of ribavirin over differing periods of time. I think the standard dosage now that we would recommend starting at would be 600 milligrams of ribavirin, but you should take into account the patient's haemoglobin and their creatinine clearance and start with a treatment course of 3 months. At the end of the 3-month period, you should check both plasma and stool for clearance of the hepatitis E RNA. If the patient has still got positive RNA in stool at the end of the 3-month treatment period, as I've said already, that is associated with the risk of relapse. And the recommendations now are that treatment should not be stopped until there's a negative RNA in stool on 2 occasions, 1 month apart.
So, bearing this in mind, that patients can develop chronic hepatitis E and they can be associated with acute liver injury, even acute liver failure in some of our cohort of patients. Do you think there is a role for an hepatitis E vaccine?
Again, I think that's a very good question. So, taking genotype 1 and 2 hepatitis E first, I think the focus needs to be on improving public health and improving the sanitation infrastructure in the areas that are endemic for genotype 1 and 2 infection. For genotype 3 and 4 infection, our focus initially, I think, needs to be on educating our patients about the risk of genotype 3 infection, and in particular educating them about the risks of undercooked and raw pork, for example. And all our patients undergoing liver transplantation should get both written and verbal advice about avoiding risky foodstuffs. Having said that, I think there is a role for the hepatitis E vaccine in a select population. So, for example, an area where I could see it being used would be in refugee camps where there are a large number of patients at risk of infection, or those patients with genotype 3 infection who are at risk of adverse outcomes, so for example the immunocompromised. There is in fact a vaccine that has been licensed a couple of years ago in China. This vaccine affords around an 86% efficacy rate and affords protection for 4.5 years. But whether it's effective against the other genotypes of hepatitis E and whether it's effective in the immunocompromised and pregnant patients, for example, remains to be seen.
We mentioned before about the possibility of transmitting hepatitis E with donated tissue and organs, and you mentioned about the blood donors. Is the knowledge that contaminated blood can transmit the infection have changed any of the policy of donation?
Yes, it absolutely has. So again, looking back to the Scottish data, the donor viremia rates have increased significantly over the past decade. So in Scotland in 2012, the donor viremia rate was around 1 in 14,500. More recent data has shown that has increased to a donor rate of 1 in 2,500. So there has been a significant increase in donor viremia rates. In addition, I guess we've not talked about the risk of transmission via solid organ transplantation, and there have been reports of the virus being transmitted not only by liver transplantation but also by renal transplantation. So in view of the increasing risk of transmission of the virus via blood products and solid organ transplantation, recommendations have been made for screening of donors. So in 2016, in the UK, blood products were screened for the hepatitis E virus for products that were destined to go to high-risk recipients, so those patients who were immunocompromised. But in 2017, the practice changed, and now all blood products are screened for the hepatitis E virus. And that's because the more cost-effective approach was to screen all blood products rather than select out those destined for a high-risk recipient. In terms of solid organ donors, all solid organ donors are also now screened for the hepatitis E virus, although presence of viremia at the time of donation of a solid organ is not an absolute contraindication to proceeding with donation. Living donors are also screened for hepatitis E viremia in addition, and those who are viremic within 4 weeks of a planned donation, there will be a pause in the planned donation until the donor has evidence of spontaneous clearance of the virus.
That's very interesting. Certainly, I have learned a lot today, but I wonder if you had any take-home messaging that we should be safely storing our memory and to ensure we're not missing any of these infections.
So my key take-home messages would be to have a low threshold for testing your patients for hepatitis E virus, particularly if they're immunocompromised, and to make sure that you choose the right test. So if the patient is immunocompetent, then an IgM antibody test is sufficient, but if the patient is immunocompromised, the diagnosis must be confirmed with HEV RNA testing by PCR. I would recommend that all patients with chronic infection are treated to prevent the risk of progression to cirrhosis, as the risk of progression to cirrhosis is around 10 to 15% in patients with chronic infection. And I would also recommend making use of RNA testing in stool to make sure that the patient is fully treated prior to you stopping your treatment to prevent the risk of relapse.
Well, all is left for me to say is to thank you for an excellent run through this very relevant topic.
Thank you.
And to thank you for joining us for Digest This.